Right, good morning, everybody. We are now going to start the open board meeting. As you'll have got from the message there, that this call is being recorded and we will be putting it on the website for the public. Give it another minute for people to join. Okay, so we're going to start by doing a roll call just to make sure we know who is on the call. I'm going to start. Suzanne, myself, and Liz are here in Chertsey House, and we're just going to check who else is on the call. Simon Marshall, not on yet. David Flack, Andrea Lewis.
Yes, I'm here.
Thank you. Who else we got? Tom Smurden.
Yeah, I'm here.
Thank you. James Thomas. No. And for the recording, just note that the executives have been stood down from the meeting if they need to do operational matters. Andrew Mawson.
Yes, I'm here.
Thank you. Mike Baxter.
Yes, I'm here.
Jane Dale.
Yes, I'm here.
Neil Haywood.
Yes, here.
Chris Ketley.
Yes, here.
Keith Malkern.
Keith, yes.
Merrick Beale.
Yep.
And Marcine Waterman.
I'm here.
Yvonne Abaya.
Yes, I'm here.
Sal Morn, are you on? I know you were listening on the closed.
Yes, I'm here.
Okay, thank you. Anybody I've forgotten?
Simon's here now as well. It's just late joining.
Okay, thank you, Simon. And we've got apologies from Louise, who's not well. So can I ask if any declarations of interest, please, for anything on the agenda? Okay, thank you for that. We'll move on to the minutes. And any comments on the minutes?
Peter, yes, I've WhatsApped you, and need to say I had a question about minute open 7:20.
Keith, you're breaking up.
Well, I'm not sure what I can do about that.
All right, try and speak slowly if you could then.
Well, if I begin again.
Yeah.
Can you hear me now?
Yes, can hear you now, Keith.
So in the last section, which is titled Norovirus, on page 6 and 7.
Yeah.
The final paragraph suddenly switches to coronavirus, and I specifically asked questions.
Sorry about the technology. Yeah, go on, Keith.
Yeah, so I raised the question about, because I said we were discussing coronavirus, but that I had seen reports about the coronavirus and how that would likely to be much more serious, and then David answered about the guidance. So I just want to get that recorded, that I asked specifically about the virus. In fact, I think that there should be a little separate subheading introduced there.
Okay, we'll amend that, Keith. Thank you.
Thank you.
Right. Any other points on the minutes? Okay. Thank you. I'll take those as agreed then. And we'll move on to the action log. finger keeps up with it. So the first action was on the People Committee minutes. There was an update that the video conferencing facility is in the process of being procured and rolled out. Simon, would you like to give the latest on that, please? Simon, are you still there? No, in which case I'll say what I know, which is that Microsoft Teams is being rolled out across the organisation. Microsoft have offered it to the NHS and NHS.net people for 3 months free of charge at the moment. And I'm aware that obviously the clinicians are being given priority on that, but that Simon is, and I spoke to him this morning about it, pushing forward with that Microsoft Teams. So I'm hoping by the time we get to our next board meeting, we will be able to use Microsoft Teams. And any others, Liz, that we need to deal with at the moment?
No, and I'm afraid I can't look either because I touched this.
Okay, fine. All right, so I don't think there are any others. There's no
one was complete, that's right.
No others for March. So we'll move on from that. So just to say that for the purposes of the recording as well, that this meeting will take only substantial questions with regard to the normal papers, and will be focused on the COVID response and assurance around the COVID response. So other papers will be brief, and we will try and keep the meeting as short as is feasible. So and we'll take papers as read. So in terms of my report, you can see that there. Like everything else, overtaken by events, a game of two halves, the 1st February being normal, March being anything but normal. Just one thing I'd like to draw to your attention was the walk around I did in Ashford in the new infusion suite, and just the praise that people in the suite were giving to not only our staff, which they always do, but to the new space. So I'd just like to compliment the estates team on producing a really fantastic new facility there. Airy, spacious, just really, really, really good. And perhaps the other one I'd like to highlight was the new nursing training facilities in Surrey University. When I went to the Kate Granger building, are fantastic and state-of-the-art, using robotic patients and technology to a great extent. And when all this current situation calms down, I would recommend a visit. We could arrange that through, obviously, our governor who looks after nurse training up there. The other bit, we are focusing both subcommittee and board now at the main issues with regard to COVID, and just assuring ourselves that the right things are being done. Other things are being done kind of out of committee with submitted questions on regular papers, but keeping these to a minimum, the aim being to free our executive colleagues, as they have more than enough to do running the hospital at a time like this, from as much of any unnecessary extra work that we can. And the board is there to support the executives at this time. And I just echo the final bit in my report, which says, take the opportunity to express gratitude to all colleagues actually across the trust. People are working really extraordinarily hard to plan, to get ready, and to serve patients and the community. And actually the way the planning and execution of the emergency measures has gone speaks volumes to the preparation we've done in normal times, actually. So I'm going to say no more there, but Chris, you have a question on NHSX.
Yes, thanks, Andy. Just a very quick one. So your dinner with the NHSX CEO, Matthew Gould, we put a few questions in I just wondered whether there's any sort of output from that meeting, and also some sort of clarification, particularly in this current, day where we are actually accelerating the digital agenda, but there is confusion around what the centre is doing, and I wonder whether there was some sort of clarification around that.
Yeah. So it's difficult to be specific because it was done under Chatham House rules, but just to say that all the points that I was asked to put were either covered or I managed to put. They are, as I've said there, they are dealing with big companies like Apple and Microsoft at the corporate level and are seeking to do negotiated deals. I suppose the Microsoft Teams thing is perhaps out of that. They like everybody else have gone very COVID focused, and indeed even during that dinner he was taking calls on COVID related matters. They are very supportive of reducing the bureaucracy around applying for funds in normal times. Took that on the chin that was very much something that people were discussing. Have got a special area looking now at artificial intelligence and bringing forward apps on artificial intelligence and getting a list of those apps that people should be looking at. I went in to the meeting perhaps a trifle cynical. I came out quite assured that he was absolutely on the same page as nearly everybody around the table was on, actually, both chairs and chief execs, and somebody we could do business with. He and I had some private email traffic afterwards. He does want, but obviously that's on hold at the moment, members of his senior team to come down here and talk to us. I described some of the things we were doing. And indeed, he asked me, given my background, if I would help them pro bono on certain matters. So again, obviously, all on hold at the moment. So I was quite assured, Chris, that actually there's somebody there who has got a very sensible outlook and is trying to dragoon all the various pieces, because I did put it to him that NHS Digital, NHS England, NHSX is all a bit confusing, and I think there's no doubt in my head that NHSX are leading on that now. Does that help?
Yeah, it helps. I've got a few more, but maybe we take it offline. And but that sort of it's interesting. We'll see how it all goes. But thanks for that, Andy. Yeah.
Because of the Chatham House rules, there's not much more I can say.
I understand. Okay. Thank you.
I haven't got any other questions notified to me on this paper, so I will actually move on now to Suzanne's report.
Thank you, Andy. I think, as you can see from my report, what I've tried to do, and as a consequence of my lived experience of the last 3 weeks, is to really focus in on our preparedness for COVID-19. But as Tom has already described, having sort of just taken a moment to check, I think the existing strategic operating framework for the organisation is fit for purpose in relation to that and creates actually a very helpful framework. So I've used that methodology to update yourselves, and I'm not going to say a huge amount more other than to say, of course, Team ASPH have been really generating extraordinary shifts in how they deliver care in order to both create capacity generally across the organisation, but also, and importantly, to create space and time to focus on preparation across a whole raft of activities, everything from a complete and a seismic shift in how we manage outpatients, a different level of thinking about who does and doesn't need to be in the organisation and who can realistically be working remotely, just in every domain. So what I think I would say is incredibly proud of all of the team, and the executive are working at a furious pace and nevertheless maintaining a sense of proportion and humour, which is extremely helpful, but actually enabling the organisation to deliver at pace and scale. And of course, the more ready we are, the more confident everybody and safe everyone will feel. So that's our focus. What I have done at the beginning of the paper, I have set out what I believe are my as a leader of the organisation, top 3 priorities, but they have, of course, been informed by lots of conversations with my exec colleagues and the senior leadership team that's really represented by the Trust Executive Committee. And in fact, those priorities have now been consistent across the last 3 weeks. So, number 1, to keep Team ASPH safe, and we can talk about that: PPE, cleaning, space, environment, skills, training, health and well-being, emotional support, a whole raft of activities to keep the team safe so that they can be effective in the delivery of safe care. To really focus on really implementing the national guidance around stay-at-home and social distancing, which I know if David were on the call, he would say he believes is the single most important intervention that can be made to avoid the spread of the virus, because clearly there's a lot of discussion about ventilators and critical care capacity, all of which is very important, but it's much better if we don't have that level of demand coming through and that level of distress and disease and the inevitable impact. So the flatten the curve terminology is very relevant in lots of ways for us, and we need to do our bit both as an organisation and a team, but also in reinforcing that national message to the public. And finally, and most importantly, I think, to keep the team informed in as open and transparent a way as is possible, with clear, consistent and contemporaneous information, which actually is proving quite a challenge, as you might imagine, because a lot of my information is coming down through multiple channels, not necessarily in timely order, and sometimes is conflicting. I don't think that's a criticism of what's happening. I think it's the reality of operating in this sort of very fast-paced scenario. I would say I think that overall the national approach has been good. I think the science it's based on is solid. I think that the leadership team at the Department of Health and Social Care have been taking bold decisions that we feel are generally in the right direction. Of course, the world is challenged by the speed and scale of this, and so the responding to that challenge with regard to things like the distribution of PPE is inevitably very, very difficult. One of the good things that we've done this week is launch our Rialto app. So if you haven't logged it or downloaded it, please do. It's really not meant as a sort of senior leadership communications tool. It's really to help the leadership connect with our very, very front line. It's a Facebook format, which they'll all be very familiar with. But you're more than welcome to download it so you can see the sort of stuff that's on there. And already there's quite good content being loaded. And what I've suggested to the organisation is that will become, from Monday, the primary means of communicating across the organisation the COVID-19 messaging. And I've had good feedback on that so far. So I'm going to stop speaking and take any questions or comments you may have.
Okay, so I've had quite a lot of comments come in from the non-executives, so on their behalf, I think we just want to congratulate you personally and the team on outstanding level of communications. I think that the email that went out last night to the team was a perfect example of the right balance, honest, compassionate and practical. So I just want, on behalf of all the board, actually, to congratulate you and the team on doing that, and also on the keeping the non-executives up to date with the weekly brief, which also now part of that goes off to the governors as well, which is very important because I know that several of the governors would normally be at this open board meeting and they'll be listening to this recording. So just to say that's absolutely right, and that the board is completely behind you with regard to your strategy for coping with this, and actually the level of communications, which is really key to maintaining morale.
I agree.
I know that I think Marcine has a question, so we'll take that now. Marcine.
Thank you, Suzanne. I agree completely. The most helpful paper. I have two questions, one for you and one for David if he's on. The question I have for you is the apps that are coming out from Imperial and King's on the ill and well, the daily tracker. Are hospitals getting any data from that so that you can do any predictor? Is that helpful? And from David, if he's on, worldwide, are we sharing the innovations and different technical aspects? And where are we, I suppose, in terms of participating in any kind of treatments? Thank you.
So I think on the first, Marcine, there are a number of trackers, applications being shared. So actually, we're using, or I've been using, the Public Health England tracker. I think those things are useful up to a point, but there's a bit of a data lag, to be honest. I think the more useful modelling information is coming probably not in a public arena, through the command and control structure that's been established, emanating clearly from the Department of Health and Social Care through the regional leadership teams and then down to organisations. To be honest, there isn't anything being described in those modelling assumptions or outcomes that isn't being really shared with the general public. I don't think through the national briefings. I think there's been a good deal of transparency. And clearly, each time the modelling is addressed or updated, I mean, what we've got to remember, this is the novel coronavirus, which means we don't really have a great deal of data around its epidemiological development or its population spread. Clearly, the academics sharing the Italian experience, the Chinese experience, the South Korean experience, and David particularly, I know, has been keeping a weather eye on all the academic papers, and we've been sharing them, but they're discussion papers really often. In terms of innovations around therapies and treatment, again, there is lots and lots of debate and suggestions and theories, and of course our job is to keep abreast of those, but also for us to implement the clinical guidance that we are being issued with. And there's been a huge quantity of clinical guidance issued through the Central Command and Control Team, all of which we are reviewing and implementing locally, and then ensuring that if there are chemical therapies, drugs, that we are able to secure supply lines through the national NHS supply chain.
Does that answer your question, Marcine?
Thank you.
David, are you on yet?
He's wandering around outpatients at the moment, so I'm afraid he's not.
Okay. No, I can't.
Sam covered it though.
Striding with a purpose, maybe, not wandering around.
Okay. Sorry, it's Andrea here. The only point I would add is that we've got a twice-weekly clinical reference group, which has all of our key sort of clinicians as members on that, where all these particular guidelines that have been coming in and the lessons learned are being discussed. So just from a governance perspective, we do have a mechanism in place with regards to that.
Thank you, Andrea. I haven't got any other questions, so I think just from the kind of open board perspective, useful to know our situation with regard to things that are in the press at the moment, so personal protective equipment and and staff testing are the things that are out there in the press as active discussions at the moment. So perhaps you could briefly just give a view on that.
So I don't think I've got anything much to add to what's in the media around the PPE. I think the national position is there is sufficient national supply. However, logistically, distribution has been very difficult, and mobilising this scale of distribution is very challenging. And it's probably just useful to be clear that we're not talking about two items that contribute to a PPE fit, if you like. Depending on what scenario you're operating on clinically, whether you're in intensive care, for example, or in A&E or on the general ward, the ensemble, which is how we would describe it, is different and is made up of many different components. So there's been a lot of discussion about masks or gowns or gloves, but actually all of these ensembles are different and comprise many pieces. So we've got lots of some bits of it and not much of other bits of it. So actually generating a full ensemble is quite challenging. But I don't think we're unique, and obviously we're escalating that all the time. And I know Simon and the procurement team have been working tirelessly to secure our supplies. We've also tried to act as a hub for North West Surrey, because actually we might feel very challenged on this front, but what I'm very aware of that is our colleagues working in the community, in primary care and in social care are even more challenged. So we've done a number of things, including share our supply, where we've been able to do that, where we've felt we've got sufficient resilience in our supply for ourselves. We've also provided training and support out to residential and care homes. Andrea and Glynis made a very good PPE donning and doffing in-house video that has been shared across Surrey Heartlands, and they've had great feedback on it. And we've actually sent personnel into local residential and care homes where there has been known positive patients to support the staff there, both build some confidence around the donning and doffing of the PPE and the utilisation. So that's what I would say about PPE. What was the second part of the question?
The second one was
testing. So testing. I think the national strategy around testing has been right. I don't want to expand on that further. I can, but I don't think we need to here. So I think that the approach has been right. The shifting from, if you like, very strict testing of people newly entering the UK from a hotspot country, if you like, right through to community testing, right through to focusing in now on patients in hospital. And that is really because the testing in hospital is very important to inform and assist us care for those patients. The requirement to test both NHS staff and the general public more widely is absolutely accepted by everybody, but they're not the same tests. They're different kinds of tests. So some of the tests have got a DNA methodology and others have an antibody methodology, and there are different reasons for securing those different kinds of tests. But clearly the priority at the moment, while there is some issue with the supply around testing, is to focus in on the patients that are in the hospital. And as soon as those additional supplies that I think the Prime Minister actually spoke about last evening are available and have been fully validated, they will be deployed. NHS and social care staff will be the first branch of opportunity, so the first expansion will be to test those colleagues for obvious reasons so that they can get back to work. And once we've got that secured, to community testing. Very importantly, once we've got an antibody test, and this is when you hear the national team talking about the game changer, this is the test they're referring to, where we can actually understand the extent to which and the volumes of the population that have already been exposed to and have recovered from COVID-19, either asymptomatically or with very mild symptoms. Clearly, if we're able to determine that the large percentage of the population in that category, then that puts a whole different picture on the pandemic challenge to the UK.
Thank you, Suzanne. I think that's very, very helpful in terms of that. And if I can just swap hats for a second, I would say that CSH Surrey Community Provider are very grateful for the help you gave them. I think it was over the weekend with some PPE, which is really, really important because community, as well as social care, etc., had dropped off the bottom of the list. I think they have had some limited deliveries since then. I haven't got any, just for the record, when I say I haven't got any questions, that is because I've got a separate app running where people are logging that they would wish to ask a question, so just for the recording. So I haven't got any down for the moment, so I would propose that we would move on from Suzanne's report and move on to the next item on the agenda. So the next item is the quality report. I'm aware this has been taken already by the Quality Committee, that the Quality Committee have asked relevant questions which will be answered in slower time. But Mike, would you like to just give a brief commentary?
No, just to reassure the board that even during this crisis, the Quality Committee met, well, at least a sub-fraction of them met, and we had a telephone conference, and we had pre-decided, as you have alluded to submit written questions which could be answered at a slower rate, therefore freeing up the clinicians. And I think we gave it a very robust review. In fact, I think in many ways it's a model that we might take forward as a way of doing it. I think just and Andrea will speak to this, I'm sure, we identified that there were some, in a thematic way, that we still were looking at falls, medicine errors, and perhaps more relevantly, infection/hygiene issues. We focused on that and also reflected that during this time when the pressures on the hospital were extraordinary, that we did need to continue to monitor those as consequences of patient care.
Okay, thank you, Mike, for that. Andrea, anything you want to draw our attention to? We're obviously taking the report as read.
Not so much really on what Mike says, only that obviously going forward, I think it's important just to highlight, I think, with the situation and with COVID, looking at the demand and obviously the workforce implications, that clearly the harms going forward are going to go up, and that's something we will keep a clear focus on. And I do have my harms-free care team who will be a clear support to the ward staff during this time with regards to that.
Okay, thank you. So I think that is important that we recognise, the board, that inevitably, with the focus on COVID-19, there will be some increase in harms, but that actually you and your team are on it in terms of planning to reduce that to the absolute minimum. Is that
absolutely. That would be correct, absolutely.
Okay. I'll take any I haven't got any questions coming through on this report, so I think, Andrea, we will therefore take that as read, and thank you very much for that report. And the questions that have been posed by the Quality of Care Committee will be answered in due course.
Yes, absolutely.
Okay. So, Mike, we had, again, seems a very long time ago, the January minutes. Anything you wanted to highlight on there?
No, I don't think so. Events have taken it over, haven't they? But so, yeah, so just to be recorded.
Okay, thank you. So, Andrea, 15.3 are the quality account priorities for the year that we do have to agree once we're out of this, once we're out of this situation.
Yes.
You want to introduce us to that?
Yeah, so we've obviously reviewed our quality account improvements for 2020-21, and we very much felt that obviously with the Together We Care trust strategy, was still very much, we want to keep in line with that, because that's a 5-year strategy. That really our priorities over the last year was, were evolving, I think. And so you'll see from the proposed priorities that the actual sort of, that there's not much change there with regards to the key headlines. However, what we have done with regards to the measurements is change those slightly to obviously improve our targets with regards to that. And so you'll see that the first one, if we just zone in on Schedule 2, patient safety, learning from errors and reducing avoidable harm and an inpatient infection, no change from last year as that is a key headline. But within it, we've gone a bit more bold with obviously reducing medication errors in harm of any severity to reduce that even further. The surgical site infection is still a key one that we need to work on, and there's lots of work that has been done on that, but we need to do better. And so we've kept that percentage rate at 5%, but we'll be keen to get under that going forward. And then the avoidable cases of the bacteremias has been sort of mandated to us anyway from a national team perspective. So that's as it is. So we'll stick with those. From a clinical effectiveness perspective, learning from death and addressing episodes of poor care again still stands. We've still kept the 100% of applicable deaths receiving an SJR, the structured judgment review. What we have brought in as a second point here is about really looking at the harms now, which is a key focus clearly in light of what we're going through with COVID. But I think it was really important, what we haven't done previously is to put particular targets on that with regards to pressure damage, the falls, the catheter-associated urinary tract infections, and also the venous thrombolysis as well. So, and what we have also included in there is the malnutrition universal screening tool, which we have got to get better at. And actually, if we can get that right and get the hydration of our patients right, it will sort a lot of the other harms out actually. So again, with my harm-free care team, we've got that as a clear focus within our strategy for that. And that will be no different actually clearly with the COVID situation. And then the third piece within that third point is the medical examiner role, and obviously we've appointed that now, and so we'll be very keen to really utilise their full extent and improve that bereavement pathway, which is really key. And then patient experience is the third piece. Again, no change with that. We'll want to really build on the co-design workshops using all of our patient and service users. And the patient feedback is key, and we've done a lot of work really in the last 6 months with regards to that, improve it, but we'll take that further even more in the coming year. And then the triangulation of the learning from complaints, concerns, PALS and series is a key area that we really do need to improve on and really exploit that to better effect. So that's really important to have that as a key point. And that covers all those points off really going forward. As you say, I think with the COVID situation, obviously a lot of this is on pause, and there's going to be direction coming out from the national team with regards to this actually as what we really do need to focus on, which will be very useful. I think for me, the key areas, as we've already highlighted, is the harms, absolutely, keeping an eye on that, and also the medical examiner role will come into its own with obviously the deaths. With the COVID piece as well. So I'll leave it at that. If there's any questions or anything, I'm happy to take.
Okay, thank you for that, Andrea. I know Keith has a question, which I'll ask in a moment. Just to say, I think the Schedule 1 there is a really clear, very helpful, the way that set out and flows. I think that's really helpful, so congratulations on that.
Okay, thank you.
I think, that it is really vitally important that we don't just shelve all of this, that we listen to the national guidance, obviously, and apply what we can going forward in the situation. So I think that's very good. I will go to Keith first.
Thank you very much, and thank you. I'm looking at Schedule 2 to draft statutory quality account improvement priorities for 2021, and really pleased to see that these are the ones that we are looking to put forward. I just want to feed in from my membership of the End of Life Care group, which now covers North West Surrey. And in terms of improving the experience, not only for patients approaching the life, but also their families, I'm wondering whether there's some sight being given to the desire of most patients and families for actually people to be able to die in other settings rather than in an acute hospital. They'd like to be in a hospital, they'd like to be at home. Is that any part of what we're looking at and talking about clinical effectiveness rather than the patient experience, but putting them together?
Yeah, but I think they very much link together, don't they? And there has been work up until obviously COVID kicked in of doing a collaborative improvement piece with all of our partners actually within the system of improving the end of life care, to streamline it better and also to be more collaborative and aligned really with our own processes in order to make the experience absolutely better and a big focus on getting people to where they really want to be in their last days, so not essentially being in hospital.
Thank you. So if when this is sort of taken into a final form, that could be mentioned or referred to in some way so that it's visible. Thank you.
Yeah, of course. Yeah, no problem. Absolutely.
Okay. And Chris?
Yeah, I guess this might be one more for the strategic change, but it does affect this as well. I guess general observation in terms of times of crisis is this whole requirement that, yes, we've got to deal with in short term, hopefully it's short term, unprecedented issue in terms of COVID-19, but also, I guess, in terms of our longer term strategic goals, I just think that it might be a good idea at some point when this is over that we just look at the targets, because it might be that, in terms of our ambition, that we might have to, in some instances, recognise that we won't be able to achieve the targets in the timescale we originally put. Likewise, in terms of some of the measures that are actually taken, Andrew, with COVID-19, maybe, such as infections, we might get there quicker. So it's just, I guess we would probably need to revisit this at some point, don't we, in the next quarter, in terms of how the timing and the target achievement might change.
Yeah, absolutely. I think that's a very valid point. It will need to get reviewed, I think, and of course we just don't know how long this is going to go on for as well. So clearly we'll just need to keep, as you say, just keep reviewing it, I think, and then make the changes as we see fit.
Yeah. Thank you, Chris, for that. So we have to approve these, Andrea. Is that right?
Yes, please.
Okay. So can I? I'm going to assume these are approved unless somebody voices an objection. So I'll just let a bit of time for people to do that. Okay. So those are approved, Liz, for the minutes. Thank you, Andrea.
Thank you.
And David isn't here. Anything on sort of the mortality report that we've had learnings from the mortality report? Obviously, we can take that as read. I'm assuming David isn't back, Simon.
Yeah, still missing, I'm afraid.
Okay. Andrea, is there anything you could comment on this?
I suppose the only thing I would say is again I suppose with COVID it's the appointment of the medical examiner, which I think is really timely that they've now been appointed with regards to obviously going into the COVID situation. So they're going to come into their own actually with regards to improving the whole sort of that bereavement pathway, but also those the reviews of death. So that's very timely, I think.
Okay, thank you. Mike, was that you?
And sorry, I'm juggling things, so I didn't put anything on WhatsApp. We did challenge, just to show that the process of governance continues, we did challenge David around the pace of the structured judgment review. So that still remains something of an issue, that we're not quite at our target for doing the right number of cases. I mean, I know now's not the time, but it's just that we did continue to review that. And as Andrea says, the appointment of the new medical officer may help to speed up that process and to deliver more scale.
Yeah.
Have we got a sense of what the likely COVID impact would be on SJRs? Are SJRs going to be required on all COVID victims? Do we have any guidance on that?
No guidance. I think we would do our normal routine as long as we can sustain it. I think we must get the learning. Every death is a tragedy for the family, and we absolutely must do our best to service that requirement as long as we can. But of course, obviously, and of course, if we don't have large numbers of deaths,
then we can do it.
Then maybe it's not such a challenging scenario. But our expectation is there will be a large number for us to respond to. But I think, what do you think, Andrew? I think we should maintain that commitment for now.
No, I think absolutely. I know David and Paul are very committed to maintaining that, and I think with the appointment now of these medical examiners and the medical examiner officers, it's so timely in that we are expecting that there will be an increase in demand, but actually we want to try and improve the service as well, and I think these appointments will be able to facilitate that.
Okay, thank you, Andrea. Jane, you have a comment?
Yes, it's just to say, first one was around the aspect that you've just discussed, which was around COVID-19 deaths, but you've covered that. The second point was, I was pleased to see on page 5 the clear description of poor care and the honest review of that, which was very pleasing to see. I'm always reassured when I see an honest account rather than something that's less straightforward. So that was very good, and it was really about, I suppose, the challenge about making sure, slightly what Susanna said about, learning and how we'll continue so that we don't lose sight of that important aspect of learning from poor care and harm and how that's going to be managed. That's going to be a challenge, I think.
Yeah. From my perspective, I think it's absolutely going to be crucial. I think with caring for our COVID patients, clearly this is going to be very challenging, but there's going to be, potentially a lot of learning that comes out of this that we've got to absolutely act upon. So, but certainly from my perspective, I'm really committed that we're absolutely on this.
Is that okay, Jane?
I suppose the only thing is there going to be any thought about a mechanism whereby good and bad practice around the management of COVID will
yeah, sure. Yeah,
and
so
actually
we're doing
where teams can learn about what's working, what isn't working, because that maybe on a regional, national, but also on our own local level.
Yeah, sure. So certainly from an internal perspective, we are 3 times a week going to be reviewing incidents connected around COVID, and then through the clinical reference committee and the group, again that learning will be shared and discussed. So we've got the forums in place to be able to do that, absolutely.
Okay, thank you.
Okay, thank you. I haven't got any other comments on this one, so we're going to close this and move on. So we have as next a COVID-19 update, but I think probably, Suzanne, there's not much more to say that Jane's going to cover anyway in the performance report. Is that right?
I would say so.
Okay.
And if we've got any questions.
I think, James, are you on?
Sorry, Andy, he's not, I'm afraid. He's with David in outpatient.
Okay, understood. So, Merrick, I know that you've looked at this in the Modern Healthcare Committee. Any sort of comments from an executive viewpoint?
Yeah, I think just because this is the public part of the board and they wouldn't have heard what I said in the earlier session, but clearly our finances, as everybody's, are under significant change right now because of COVID. At our last modern healthcare meeting, which obviously is after these minutes, we discussed extensively the mechanisms that the government are putting in place for hospitals to address COVID, both in terms of the impact on additional costs, but also disruption to existing work. And we took significant assurance that the financial control of the hospital, both as it was and as it has to be now under COVID, was being given very detailed scrutiny. And we felt fully assured that we would be compliant with the information requirements for the extra funding that we would be seeking, and also the impact on the existing day-to-day business of the hospital.
Thank you, Merrick. Mike, from the Quality Committee's perspective?
Sorry, Andy, in terms of what?
Just in terms of performance, yeah. Particularly, James has done some of the COVID preparations, etc.
Yeah, so I think James at the committee really donned his gold commander hat, and that most of the discussion was related to the obvious pressures of COVID on the system. We noted the report, but most of our conversations were about the present crisis. So I think I would defer any comments to him being able to speak.
Okay, thank you. Susanna, is it worth just stating kind of what the current COVID loading is on the hospital?
I think that we've had so far 10 COVID positive patients, although what we've seen is a gradual increase. But those are confirmed positive patients, and the vast majority of those patients have gone to intensive care. And I think this morning our numbers are edging up in intensive care. We've got something in the region of 50 patients that are suspected COVID patients and are awaiting their screening results. And thus far we've been able to manage that sort of workload through a dedicated respiratory care pathway that runs directly from A&E to a cohort ward. And then when we have patients that either clearly need to go to intensive care or are confirmed positive, we're able to cohort those patients, obviously trying to protect patients that are clearly not in the hospital because of COVID scenario from the risk of cross-contamination or infection, at the same time as treating the patient in front of us, really. So the testing is important, but it doesn't hugely influence the treatment and therapy that we give a patient with symptoms. And of course, until such time as you've got known to be effective antiviral therapy, then we're not able to add that as an adjunct at the moment. What I would say about our load in the hospital is that, interestingly, we do seem to be running slightly lower in terms of specific COVID demand from some of the other hospitals locally, and we're not quite sure why that is, and whether that's just a sort of a delay, and we'll see more patients. But the hospital, yes, is quiet, and that is really reflected in these figures, because of course there's a timetable lag with that. But we're seeing very, quite significantly reduced demand through A&E generally, and the UTC, which you might expect because people are heeding the advice and using other means to get assurance. And of course, all of our planned surgery, other than urgent, have been deferred, and all of our outpatient activity has essentially been moved to virtual telephone. So the hospital feels eerily quiet for a place that's operating in a crisis. It's a bit kind of gives you the impression that we're not in the midst of it. But of course, all of the patient care, where these patients are being cared for, is an extremely heavy load, and is all happening essentially behind closed doors. So the organisation does feel calm, I think. I mean, Simon, you've had a walk about this morning, and Andrew, Ashford. What's your feeling?
We're extremely quiet. Andrew.
Yeah, I mean, I definitely say that it is quiet, but there is a calmness around the place, and obviously, from my perspective, I've had a big focus on visiting the areas where we're treating suspected COVID and also the positive COVID, so patients, and just giving the reassurance to staff and stuff. They're doing a fantastic job, I have to say, and being, there's calmness about the place. It's really good to see. I mean, there's slight anxiety initially, obviously, when this all hits, and that's very, very understandable. But we've been doing a lot of work, and there's some good leadership coming to the fore with regards to really supporting the staff through this, which obviously we'll have to continue to do in the coming months.
Yes, absolutely. I think that's a really important point, Andrea. Thank you for making it, because I think what we mustn't sort of move to is a sense of complacency. It's not going to come, it's not going to happen. We need to be ready, and those of us with military experience will know that sustaining the readiness is often as challenging as actually delivering when the time comes. And I think when certainly when I talk to colleagues in London, or I talk to colleagues that are supporting the 111 service, which is obviously the first point of call for the general population, I mean, the level of demand is extraordinary. So it's gone from the tens of thousands of contacts a day to the millions. Wow. So, you can see some of that will be worried well and people wanting to secure testing, but some of it's genuine demand, of course. And of course, people are still getting sick with all the things they normally get sick with in an emergency or acutely unwell. So that's important for us not to forget those patients or do them a disservice in any way.
Okay, thank you. I think we'll move on from that. Just briefly, balanced scorecard. Simon, I think Merrick and yourself covered the fact that we are obviously tracking the specific COVID spend, and that will be kind of logged and reimbursed. Is there anything else to say on the finance side for the open board?
I mean, just effectively, because of the underwrite we expect to break even for the next, 4 months, essentially.
Yes.
Yeah.
Okay. That's fine. So people, obviously Louise isn't on the call, but Marcine, I know you had a people committee. Is there anything you want to draw our attention to from that?
Thanks, Andy. We, People Committee, focused on 4 issues: staffing, sickness levels, system-wide staffing, and training. And I'd say 4 things came out of it. One is, you might have seen this morning, that Ashford and St. Peter's has issued HR guidance. It's been put out on their app, and that came down from the national guidance and then locally translated, which is excellent. You'll have heard already this morning, we're changing induction and training. We recognize, one, we need to move people on faster, so we'll have 2 to 3 inductions a week, but they will only be half a day to get your pass and to get your kit and your uniform. The rest will move online. So the team is definitely evolving our approaches. Same with training, reinvigorating that, but online. Recognizing that what's happening currently. There is, Suzanne's already mentioned it, in terms of sickness levels and self-isolation and reporting, and they're evolving how they're collecting that information. I think we've already mentioned it, but we talked quite a bit about the well-being being supported to staff, and of course the announcement that car parking will be free from April. There was some discussions about when we first closed schools about how to get our key workers' kids in school. There was some issues about having to verify staffing, but that's all been sorted. And of course, recruitment, we're having to do it a bit differently, deferring actually at big events, but moving to online interviews. I think those are the key points. We took an awful lot of assurance about the activities that are going on around the staffing people agenda. Thank you.
Okay, thank you for that, Marcine. I think that probably covers most of the people side, unless, Andrea, you've got any comments from your point of view? Nope. Okay. Suzanne's just stepped out, by the way, because James had an issue that he needs to discuss with her. So we'll push on through the agenda. Merrick, the modern healthcare minutes, I'm guessing nothing particular to draw our attention to there?
No, I covered it in the earlier part of the discussion.
Okay, thank you. People Committee minutes, Marcin?
Same as I've mentioned. Thank you.
Yeah, okay, thank you. The National Staff Survey results, we can come back to that when Suzanne is back. We'll move on from that. Simon, briefly, the place report.
I guess broadly it was kind of as expected. We do very well on areas like food, but clearly we're struggling a little bit now around privacy and dignity as we're being very busy and being unable to do our maintenance works for some time. Again, this year with the COVID, we were not expecting to be able to get to a full ward refurbishment. So I think we're struggling on those privacy, dignity fronts. Yeah, and I'll let Marcin in though.
Okay, Marcin.
Thanks. I mean, I sent it in, but it's just worth because Mike's raised it from Quality Committee as well. I mean, we had a report on the mock inspections showing hygiene and cleanliness to be wanting and requiring recruits improvement, and yet we've got the place audit saying cleanliness is basically excellent, above national average. So I just wanted somebody to triangulate that and explain to us the two findings. Thank you.
Thank you, Marcin. Simon, any comments on that?
Yeah, place is more of a public-facing. It's not solely that, but a lot of the areas it looks at are where the public are. Clearly, some of the quality side of things, you're bringing in more, testing results and, pathology and other kind of things behind the scenes as well. So one's an impression and the other one would be scientifically backed, perhaps. Can I describe it that way? Yeah, and more backroom kind of areas. So they're different views. Yeah.
Okay. Can I ask one, Simon? In terms, the one thing that worried me about the place one was the patient records being visible to the auditors on the day, because this is something I've picked up 2 or 3 times on walkabouts, where sort of doctors in particular seem to go behind the curtains to deal with somebody and leave the patient records on the table kind of outside, which obviously in normal times is, visitors and anybody else. So I was wondering if there's, and maybe Andrea wants to comment as well, whether there's kind of any particular action being taken around this.
So we've taken actions in the past, for example, putting physical lockers and those sort of things for records on wards. But fundamentally, as we're interacting between patients and the records, it's a constant challenge where they're paper based. We ask everyone to be vigilant and to make sure that's not the case. But the reality is we still have challenges, both on the wards and in outpatients, I think it's fair to say. Really, we're looking for the electronic medical records to resolve this issue once and for all. But even with those, you can still peer over people's shoulders if they've, left those open. So it's a staffing behaviour challenge ultimately.
Yeah, and I just add, I mean, this is huge actually, and as Simon's already mentioned, it's not just the paper aspect. It's also on screens as well, on terminal screens. People leaving, walking away from their terminals when there's information up there. So we're constantly having to reiterate about this to try and improve. It's a key thing that CQC brought up as well. But the electronic patient record will go a huge way to improve it, albeit not eradicate the issue totally. But we've just got to keep pushing. I mean, that's one of my focus, is just keep pushing the message and trying to change the behaviour over time.
Okay, so the assurance we can take then is that it is high on your agenda then, Andrea?
Yes, yeah, it is. It's one of the key, that and cleanliness is 2 key areas that we've really got to get better at, and it's a key focus.
Okay, thank you for that. I haven't got any other questions on the place notified. Mike, you wanted a comment on the people side?
Yeah, just because we've talked about induction training and things for, you know, staff and for people that are coming through the normal process, but of course, the trust, well, so that's part of the question, I guess. You know, the news tells us nearly 500,000 people have volunteered, and so I just wondered what the arrangements would be to cope with and allocate those people for function, and whether the trust is making a more specific external appeal for people to come back.
That's a great question, Mike. I don't know if, because Suzanne stepped out at the moment.
I'll have a go. It's Tom. We are aware of this. We've actually had people come forward to us from different sectors who are now facing unemployment as a result of this. And we're seeking to find ways through the measures that Martin has described to bring those people on. We've got further discussions to have about the approach to this, and you know, whether we take a kind of recruit to the person approach as opposed to recruit to the job description, and how flexible we can be. But we're definitely considering it.
So Suzanne's just stepped back in quite unfairly. I'm going to first of all tell her what the question is, which always helps. Mike was asking the question around volunteers what we were planning to do with any influx, induction, training, etc. Tom's given some part of that, but obviously we are having a lot of people volunteer their services. Is there a sort of general view on how we're going to handle that?
It's being done nationally. That's what we've all been told.
The 500,000 is, isn't it?
Yeah. So I think that's where we're going to be able to direct everybody to.
Okay.
Same with return and retire, or any of these people that are volunteering. Because the problem is, I think some of the difficulty is if some organisations will get lots of volunteers, some may not.
Yes.
And really there does need to be strategic oversight and make sure the volunteers are pointed on the areas that really need it most and where the intensity of activity is. So my impression is that the either at national, so nationally they're collecting the volunteers. I'm sure the lists will be distributed to region and there'll be a sort of a filter down. And much as they have done with the independent sector provision, there will be sort of at probably ICS level negotiation about how our, if you like, allocation is done. Beyond that, I haven't really had any thought other than sharing any information I've got with our existing volunteering team. And it may well be that locally they've been working on something with Tom and others that I just haven't caught up with. So if Tom said anything very, very, very different, I apologise.
No. I think it's very consistent.
No.
Okay. I think the only other thing we were talking about place was the patient record being visible to the auditors. I raised that because that was the comment there, and Andrea has assured us that is one of the top things on her agenda, and that Simon has said obviously that electronic patient records will help with that in the long run. But this is a culture thing.
I mean, records and securing documentation, as we know from our CQC and other things, is always particularly. Going back to the visit to volunteers, actually, I think the other thing about it is the Surrey Vulnerable People Hub. So I think actually it may well be that hospitals aren't a great place for volunteers to be in the current climate because of all the reasons we can imagine. But actually there is a huge demand for providing support to the vulnerable who are self-isolating or in one of the most vulnerable groups that have got an underlying. So I think actually that there's a lot of work being done around mobilising visitors to that as a specific and new need that we didn't really have in the community before. And I've certainly seen quite a lot of detail around how Surrey County Council have been mobilising that, a hotline and various other things. I would imagine a lot of the volunteers will be pointed on really community support, taking people to and from appointments, taking them their shopping. I think they're calling it contact and chat as well, sort of for people that are at home.
Okay, thank you. The one we skipped over when you weren't here, given Louisa's away, was the National Staff Survey results and next steps. But I think we probably just take questions on that, didn't we?
We did.
We didn't get the paper anyway. Okay.
It went. Well, the paper, probably the paper went to governors. It went to council governors, didn't it? Well, maybe I'm imagining that. I think it was. Or went to tech.
Went to tech.
And then there was next step.
Okay, we'll defer that.
Did go to tech.
We'll defer that because we haven't had the paper. So I thought there was something I missed.
I was wondering why there's an empty space, and you know it's not downloaded.
Exactly. Chris. Chris, are you there?
Sorry, I forgot to go off mute. I don't know whether this fits in place. Yeah, whether this fits in place or what. And Simon and Suzanne will know. But it's really interesting. What this COVID-19 has accelerated is obviously more people working from home. And last week I had a call with Laura about the up-and-coming IDC meeting, and what she said, and Suzanne mentioned it as well, not today, but another meeting, that it's drawn into very sharp focus the whole role of IT and how it supports the hospital, and that, you know, if IT people are all sitting in a room and they get COVID-19, the infrastructure will fall apart very rapidly. And so there's a lot of IT people working from home, and that's necessitated Laura having to order a whole host more laptops, I think 70. And I just don't know quite where it fits in all of this. And I just wanted to maybe just raise that and ask if Simon or Suzanne have got any sort of further observation on that or further comments to make.
Shall I go for it? So behind the scenes, the IT team have put in a huge amount of work into strengthening particularly our infrastructure. So it's not just the PCs, it's the pipelines, it's the servers we've got to manage people working from home, it's the help desk calls, it's everything else. So they're doing a huge amount. They're also doing it with a number of their own team that have, that are off through illness and the rest, or self-isolating. So it's a tricksy time for them all. But so far we've managed to respond pretty well, I'd say, and they're putting a huge amount of effort in. So all credit to them for everything they've achieved.
Okay, Suzanne's got nothing to add to that. Chris, okay?
Yeah, no, it's fine. I just wanted to just acknowledge it really, and I'm not sure where it fits in here. Probably within the balance scorecard, probably in ITC for the future. But it's a real live issue and dilemma, I think, and I think the team has done an incredible job tackling it.
Yeah, I think it was in Suzanne's report under digital, Chris. But certainly the guidance has gone out to staff to only use the secure keys when they need to access their network drives, etc. And if they're just doing kind of email, etc., they can work without that. So that's sort of trying to take the weight off that, particularly the remote access server is a big issue.
Yes.
Okay, so going to move on to the strategy and planning. Neil, any points you want to make on the Strategic Change Committee minutes?
No, thank you. I think they're a recording of our meeting, and obviously we postponed this afternoon's committee for all the good reasons we've been discussing.
Yes, thank you for that, Neil. Just to make the point that wasn't in my report because it happened this week, and for Andrew Mawson to note as well, and Tom. I had a discussion this week with Helen Petterson, the new chair of North West Surrey, and one of the things we went through was in calmer times, the need to kind of elevate the anchor institution discussion to North West Surrey level, and she was very supportive of that. And I think it is the right place to coordinate that with community, with GPs, PCNs, and ourselves. So I just wanted to make the point that we had that discussion, and Andrew, you may wish to talk to her in due course, Helen Petterson.
And just Andrew, I'm talking to her tomorrow actually, so we're going to catch up tomorrow, and that's all very helpful.
Great. Well, that's very apposite then, because we only spoke a couple of days ago. So it's bang up to date, and I think you'll find her very supportive of that.
Oh, that's helpful to know. Thank you.
Okay, great. Now we've Keith, any points on the Audit and Risk Committee minutes?
Yes. So if you've got that open in front of you, it's 18.1. Those are minutes of our January meeting, and I'm just going to give you 2 or 3 quick updates because we've subsequently met again last week. So in minute 2, there's a comment reported there about the poor quality of some of the papers that we were getting from our internal and external auditors being tabled. I'm pleased to say that at our March meeting, there was a distinct improvement, and we are much more efficient as a committee. So that matter has been addressed. Similarly, when you go down to 4.3 about the follow-up of audit recommendations, again, we had reflected back in January that there had been disappointing progress, but by March, very pleased to say that nearly all the outstanding recommendations from prior years had now been dealt with, and we were making good headway in the current year. So again, quite a significant turnaround. Appreciate obviously a lot of work in that area will now go on to hold, but at least we have managed to clear some of the backlog. And then the other sort of outstanding issue being carried over, is the job planning for consultants. And this is a longer running issue. There are recommendations that the internal auditors have given us that are quite wide in their scope. And we would normally be, and David will be leading on making some significant changes on this, and we've got a bigger piece of work underway. But again, that's going to have to go on hold for the time being. So just to say, reviewing these, we haven't yet had a chance to get our minutes out for last week's meeting. We will in future be seeking to time the audit and risk committee, so that it's not so close to the main board, and then we can get a better flow of information to you.
Okay, thank you, Keith. Can I just ask, in terms of the formal audit, has that now gone on hold then? Because obviously they can only do it remotely, I'm guessing.
Yes, so again, we've had a discussion around that last week. Quite a lot of work can be done remotely. For example, also in counter fraud, instead of doing on-site training, time is going to be spent now looking at the increased activity in the sort of cyber security risk area. So we're refocusing some of the work going forward. But in terms of the timetable, we're anticipating that we haven't yet, I don't think, had national changes on this.
On that, if it's helpful. The
audit, please. Yes.
Yeah, the audit's going to be, from a submission point of view, is going to be slipped by 1 month, so from May to June, essentially. From a production point of view, Paul's got a weekend longer, so all the extra time has been given to the auditors, which I think might be a little short-sighted, but nevertheless, the annual accounts have been slipped. There's no audit requirement anymore on the quality account side of things, so that's been stopped for the year to take the pressure off. But broadly, their timing changes at the moment, and the auditors will be expected to somehow conduct an audit remotely. We're still working on that bit.
Okay, thank you.
Can I ask a question? We at the auditors, one of the issues they couldn't do is anything on site, which was stock take. Has anything come back from audit methodologies that allows them to change their approach?
No, Marcine, but I mean, essentially, the vast majority of our stock we count almost on a daily basis now because it's materially managed. So I think when they look at it at the end of the day, it's not a material number, really. So I'm not expecting that to be a particularly problematic area.
Okay, thank you.
Okay. Well, have you finished, Keith?
Yep, nothing else to say, thanks.
Okay. I haven't got any questions logged here on that. Marcine's done hers. So we'll we'll move on from that. Thank you very much, Keith and Simon, for that. Trust seal, this is just to receive, Simon?
Yeah, quite a few on this one. Various older ones, but essentially the bulk of them are to do with the West site and the delay to the receipt of the £6 million next instalment that was due to us in return for Carla creating additional car parking for us. So I think you've all been briefed on that previously. It was just the final legal documentation to vary the contract and put that into action. So our next payment will be £6 million due in November on that. The other issues were much smaller, but I think there was probably 6 of the 8 items on there were Carla related.
Okay, thank you. I'll just to highlight, Simon, I'll come back under AOB just for you to give a brief. We haven't had the estates update in terms of what's happening. Obviously, the public will be interested in what's happening with the car parking and all the new ward in particular. And I'll just give you advance warning on that one.
Okay.
So we move on from the trust seal then. I haven't got anything else on that. So we move on to AOB. Mike, you had a brief AOB point on the app, I think.
Yeah, so it was mentioned earlier on that there are a number of tracking apps, and what they're attempting to do is to identify people who have or have presented with symptoms to try and get an idea of the proportion of the population that may have already been exposed to. I just got an update from the King's app, which I'm contributing to, which suggests that 6.6 million people may have been exposed based on their symptoms. And why that's significant, of course, that's over 10% of the population and speaks to a growing herd immunity. And it also speaks to the importance of the antibody test to be able to identify whether or not you've had it, because it suddenly liberates a whole lot of people from the worries and anxieties about whether they might get it or not. So, I mean, that's just an optimistic view. I know it's nothing to do with the trust specifically, but I just thought, as I had it on my phone, I would share it with the board.
Okay, thank you, Mike. Simon, do you want to just pick up the estates briefly?
Yeah, this falls into a few schemes. So the new ward, the new AMU, we're hoping to receive handover of that on about the 7th of April. So that's just subject to the final fitting, particularly some of the sinks and the plumbing side of things. But so that's the main thing that we've been pushing to close and complete, really. The main car park is probably about a week behind at the moment. Some delays, mainly to do with the ground conditions. It was quite wet of late, so and there's a nervousness about the availability of those builders due to COVID-19 and those sort of concerns. But essentially, that scheme can operate in the car park independent of the hospital, so we're ploughing on with that one. Carla and Optivo, it's not quite as urgent from their point of view, and we seem to be in a situation where they're slowing down activities now, not surprisingly, in terms of the building sector and those sort of things. I guess that's probably the main one. The final one is probably just we're due to exit the west site completely at the end of March, so what's that, 5 or 6 days away? And we're pretty much on track with that. So you'll see a lot of works, particularly at the bottom of the ramp near the energy centre, that are nearing completion now to relocate those final estate services off-site. So broadly, we're in a pretty good position, I think. Obviously, there may be an impact in terms of next year's schemes and our ability to start those, given the wider issues, but we're dealing with that on a case-by-case basis.
Okay, thank you, Simon. I just wanted that sort of as just a matter of record, and quite right, the priority going to obviously the extra ward space that we need. Chris, do you have a question?
Yeah, just a quick one. Simon, in terms of the government and construction workers, if the rule changes, Is the NHS prioritised in any way in terms of, building work that's required, such as what we're doing, or would those sort of any restrictions apply to us as well?
So I think the answer to that is yes. I mean, clearly, if we're building a ward, for example, then that's considered to be essential and a priority. However, at the opposite end of the extreme, the residential accommodation Optiva or Ocala are building clearly wouldn't be. So I think we're likely to see slippage in some areas, but not the core ones for us. I think the impact would be...
Would car park fit into that?
I think the car park, because it's a hospital site, still falls into that essential category. At the moment, there's a huge amount of steel that's already been made and is waiting off site to be delivered from next week. So, the intention is to keep that one moving through. And as I say, because it's outside and remote on a hospital site, I would consider that still fall within the essential category.
Great, that's helpful, thanks.
Okay, thank you for that. Just from a kind of an AOB point of view, I haven't got any other AOBs notified at the moment, just for the board to be formally notified that Dr. Mike Baxter has been accepted as a non-executive director of Frimley, and that given the current situation, we would seek to get our governors to agree to dual running. For Mike. Mike is happy with that. I will confirm that with Chair at Frimley as well. But just to congratulate Mike on that appointment. But as I say, that's not to say that Mike is stopping working with us at the moment. At the moment, we are anticipating a period of dual running until we can get a recruitment up and running, and that obviously is not appropriate right at this minute. So that's just for the formal minutes. I would take any other business if anybody has it. Liz, we have had some questions from the public sent in.
We have, which are being considered and will be responded to.
Okay. And so we have had questions from the public. They will be, they have been formally noted, and we've written back and said that we've got those, and they will be responded to outside the meeting. So that's the way we're handling questions from the public, and indeed, whilst this crisis continues, we will not be having public at the board meeting. We will continue to record our open board meetings and to take questions from the public via the website and respond to them accordingly. And obviously, the responses need to be public as well as they're done. Okay, so just to say, I think we may have to, given we're now in March, given the current situation, we may have to reconsider going to every other month for board meetings, but we'll take that offline at the moment. So I know the formal date of next meeting at the moment is the end of May. Given this fast-moving situation, we may have to amend that. So I would like to thank everybody for their contribution today. Thank you that we've kept things much briefer. And it is now 20 to 12. And thank you to the executive for being so flexible in terms of giving your time when I know that time is very valuable. But I think today it is important that we show that assurance does continue. And interestingly, several members of the team talked to me this morning about seeing this happen is actually quite calming. The fact that this is happening, and I think as we move to Microsoft Teams, hopefully next one it will be perhaps easier than it is on a telecom. But thank you for submitting the questions via the WhatsApp. Or the wish to have questions. That's been helpful, I think, for control. And I would say keep safe, everybody. And perhaps in the immortal words of Dave Allen, may your God go with you. So thank you.